It means a lot. This is the best job I've ever had. It means that you have your finger on the pulse of clinical education. That's what we do. That's what we're all about in pulmonary critical care and sleep medicine. It means that you're relevant. It means that you're sought after. It means that you know what's going on in the inner workings of one of the leading pulmonary journals in the galaxy. It means you get to work with great staff. It means you get to travel the globe. It's fun. Our annual meeting is to fulfill our mission, which is really to be the leader, the global leader. At least that's our mission, is to be the global leader. I personally think intergalactic would be more appropriate in clinical education, in pulmonary critical care and sleep medicine. It's a big job. And not just for physicians. We've opened our membership to the other people that work with us in the hospital corridors, the ICUs, the sleep labs. So our membership is now open to respiratory care practitioners, to nurses, and to other people that work side by side with us in teams. I think every individual who comes to CHEST gets something different that is peculiar to his or her own needs and interests. But to get at the question that I think you're answering, we are working on educating in teams. So we might have a session on how to manage a problem in the ICU that isn't so much aimed at whether you're a doctor, a respiratory therapist, or a nurse, but aimed at whether or not your work involves care for the patient with adult respiratory distress syndrome. So we're doing some of that. We are having a few sessions specific for example, respiratory care practitioners, but those kinds of divisions are artificial now. If you take care of sepsis, you take care of sepsis, and we're here to help you learn to do that better. What's big at this meeting this year is early detection of lung cancer. Just recently, we now have pretty compelling data that high resolution or low dose CT scanning can pick up lung cancer perhaps early enough to perhaps reduce the appallingly high death rate from lung cancer in this country. This is a controversial idea, but the government, the CMS, has now agreed to pay for this procedure, and so it is beginning to happen. And the challenge for the people in our membership is, who are the candidates for this? How do we interpret the results? Because it's not just about a test, right? It's about the care of the patient. And people have come to learn in large part how to implement this, what it means for them and their practice. They should read the peer-reviewed literature very carefully because there will be criteria for which patients are appropriate to screen and which patients are not. And there is a partnership and decision making. When a patient is going to undergo this testing, there has to be some joint decision making about what to expect and what the outcomes are. Pulmonologists need to know about this. General practitioners do need to know about it because they're on the front lines and their patients are asking about it. Frankly, a general practitioner probably needs to know more about this than I do because my practice doesn't include these patients generally, but their practice includes everything, and I don't know how they do it.